Okay, so I'm going to turn it over to Dr. John Brooklyn, and I'm really excited to hear about Vermont's approach. Many of you may know that the new Cures Act has given us an opportunity for almost $89 million in California to focus on building out addiction treatment. So if we get that grant, which we're still working on with the Department of Healthcare Services, a lot of that grant is based on this Vermont Hub and Spoke model. So I'm really excited to have John walk us through. So John, take it away.
Thank you so much, Kelly. You are a great introducer. I was so inspired by just what you said and the way that you presented it. I'm really grateful that you've asked me to be part of this. So just for reference perspective, Vermont has only got 600,000 people. So when you talk about LA being a small country, we're actually a very small state. But we had challenges with opiate dependence like anyone else, and our history is a little bit different in that methadone came very late to Vermont. Not until 2002 did we have our first methadone clinic. But because we had a lot of research at UVM on buprenorphine, we had a lot of doctors throughout the state prescribing buprenorphine. And what we realized as more and more methadone clinics opened, that we really had a disconnect between the OTPs or the methadone programs and the docs in these rural communities who were prescribing buprenorphine, because patients can get fairly complex. And when you have a waiver to prescribe buprenorphine, you're not really an addiction expert. And so a lot of people were losing treatment. And in the early 2010, 2011, I began to think about a robust system of interacting between doctors' offices and these opiate treatment programs, just like you would for an endocrinologist or a cardiologist, that we needed a robust system of referral and connection. And so with that in mind, the state of Vermont developed this model that we called the hub and spoke, the hubs being these, as you can see in this slide, the center of treatment on a high level where you'd have complex situations which would require methadone. And then you would have the spokes in each county that were linked with a single OTP. So for instance, in Chittenden County, which is the largest county in the state, it's about 120,000 people. We had one clinic, and all the docs who were prescribing buprenorphine could refer to that particular hub. So we linked doctors in the community with the program that was closest to them. In establishing a hub, what we really intended to do was also have the hubs prescribe buprenorphine so that they could either take people as referrals from the spokes, or they could start people on buprenorphine and then refer out to the spokes. So it was a bi-directional system. And in going back one slide, as I mentioned, the impetus for this was to really improve access to addiction treatment and to really try to integrate substance use disorders into primary care, which is really where they belong and not in these specialty silos or separated out from the rest of medicine. So input into this system of hub and spoke, as you can see in the slide, can come from a variety of areas. People could be in a mental health situation, they could be coming out of a residential program, they could be coming out of corrections. We actually have a fairly substantial connection with the correctional facility so that if someone is coming out, we try to get them into treatment immediately to reduce the risk of overdose and death. And then we have patients coming out of the hospitals, coming out of different medical homes. The other component that we'll talk about next is the fact that spokes in and of themselves are not just a doctor. One of the things we recognized in surveys was that many people, many physicians who had a waiver really felt as though it was a difficult disease to take care of, and they really limited the number of patients that they had. In fact, many docs who get the waiver don't even prescribe buprenorphine. So in surveying a variety of these folks, what we came to realize is that they needed resources just like our patients who are diabetic. They have diabetic educators, nurse educators, dietitians. So we created what's called a MAT team, which is a medication-assisted treatment team. We'll talk about that in a minute. But the idea was that if you could provide the physicians who are prescribing this additional work group, it suddenly would allow them to increase the number of people that they treated and help their comfort level in taking care of patients who had substance use disorders. And as you can see, the spokes can be any one of the following practice settings. Obviously, a lot of primary care physicians, most of the federally qualified health centers in the states became spokes, and that's a very important point, because when you take complex disease like substance use disorder and you're in a community health center, the resources in a community health center are vaster than that in a primary care setting, and you get the cost-based reimbursement. So I'm a firm believer that all FQHCs should have a robust buprenorphine program that would allow the use of these adjunct groupings. So what we did is we allowed any buprenorphine provider to become a spoke. Initially, we had about 120 physicians that were designated as spokes. And the MAT team comprised of one full-time equivalent case manager who was a master's level. It could be a master's level substance abuse counselor, master's level social worker. We didn't determine, but because of the funding through the ACA, it needed to be a master's level. And then a registered nurse per 100 buprenorphine, or in the case of naltrexone, although that's quite rare, 100 patients for Medicaid. So what we did is that the services were provided either in-house. So for instance, in the case of an FQHC, they might decide to hire that particular individual, or in the case of some of the smaller practices, we would have contracts with the hospitals or the mental health service providers who would hire the MAT staff and then deploy it throughout the area. So for instance, let's say you had a primary care doc who had 7 patients, and another one who had 10, and another one who had 5. We would give you 0.1 FTE of the full-time equivalent. And that may not seem like much, but the MAT team would be able to reach out to patients and contact them or go to the physician's office. So some cases the MAT teams are mobile, and in other cases they're embedded in the office. But we allowed flexibility with the programs, with the idea that over time they would increase their capacity and use more and more of the MAT team services. The payment model was $163.75 per member per month was what the funding stream was, and we paid it through what was called the Blueprint Community Health Team. In Vermont, we have a Blueprint for Health, which is a Department of Health mandate that designates chronic diseases, and because substance use disorder was designated as a chronic disease, the payment came through that. Let's see, I've lost my slide. There we go. In addition, I created this, what I call a treatment need questionnaire. I took the addiction severity index that's widely used and broke it down into certain subsegments. And what we were trying to do is have a tool that would be useful in terms of determining, should a person go to a hub or should a person go to a spoke? What's their level of need? And so we developed this questionnaire, and we would give it to people on intake or even when they were calling for treatment, and we would score it. And you can see here that we separated out the scores. So if you scored a lower number, you'd be more likely to be an office-based candidate. And if you scored a higher number, you'd be more likely to be a hub candidate, so that it helped docs in the community and the MAT teams have a little bit of a sense of who they were dealing with at the front end, and perhaps make a referral to the appropriate site. And then once people were in the spokes, we also had the Dartmouth folks develop what we call the Office-Based Stability Index, whereby there's a series of 10 questions that a physician could quickly use, or the RN, the MAT staff, could quickly use to see whether the person was still at an OBOT, office-based level of care, or whether they needed to be referred up to the hub. And the other thing about this is that there's a very robust transaction. So if someone's in a spoke and they're doing poorly, a referral to the hub goes out by the case manager, and we will take that person within a week or 2 of being referred, so that the physicians feel as though they can easily take on a complex case because they know they have a referral basis if they need it. Some of the challenges that we faced were what I mentioned earlier, is that we really needed to get people the kind of care and help that they needed. So by giving them this particular MAT team, we were hoping that docs would increase the number of patients that they took care of, and also that we'd have an increase in the number of physicians willing to become buprenorphine providers because they knew that MAT services were available. The funding was from the Affordable Care Act, Section 2703. It was a 90-10 funding split initially in the spokes, and after 8 quarters, that funding ended, but the state of Vermont has continued to fund that after the 2 years have gone by. So what we've noticed is that we had an increase in the number of waivered physicians, and we also had an increase in the number of patients that waivered docs would take on. We had, as you can see here, the MAT teams were deployed in over 80 different practice settings. We had an increase of Medicaid patients to 2,600 in the OBOT system, and we had an increase in the number of physicians who were becoming waivered for 100, and the doctors overwhelmingly felt as though this was a very positive help for them in terms of managing their caseloads. As you can see here in 2012, which was pre-hub, we had a total of 650 people in OTPs and or hubs and 1,700 in spokes. In February 2015 and then February 2016, you can see the growth. The hubs increased by 4.5 times. The spokes kind of stabilized for a period of time. But when you look at the number of people who are OBOT completely, it was about 3,500 individuals. So we had a doubling in 4 years. And of that, about 68 to 70% were Medicaid. And then you can see that the number of waivered docs as of 2016 who had a 30-patient waiver was 269. It went up by 100. And then the number of docs who were at 100-patient waiver doubled in number. And then the very important thing we'd like to point out is that given the access to care, in which there's really only one clinic in the state where there's any kind of a wait, we had a significant drop in our overdose deaths from 2013 to 2014. We've referenced the rest of New England here. We have Vermont, and we have New Hampshire, Maine, Massachusetts, Connecticut, and Rhode Island, but we had an almost 8% drop in overdose deaths with the introduction of the hub and spoke, because people wouldn't lose their treatment. If you were doing poorly in a spoke, you would be referred to a hub. If you were referred to a hub, you had a choice of medications, either methadone or buprenorphine. So we had people who felt as though they could stay. And then almost at the end of the slides here, we have the higher MAT treatment costs were offset by lower non-opioid medical costs. We had initial Medicaid savings of $6.7 million, and we know that there's a lower utilization of non-opioid medical services once people are in medication-assisted treatment. They get all their other problems tend to be taken care of. And then the last slide here is that because of this buprenorphine being allowed in the OTPs, or the hubs, it allows for bup to be offered in either setting. We carved out the cost of buprenorphine so that it's a separate funding stream through Medicaid to pay for buprenorphine in the hubs. And then we also worked with various regulatory agencies, the Department of Health, the Medical Practice Board, the Medicaid Division, to try to streamline and get all our different rules and regulations in one place so that we were all marching to the same beat, in the sense that they didn't have different and diverse rules depending on the setting. So in summary, it has been a benefit for the state of Vermont in terms of increasing access, reducing overdose deaths, and also keeping people in treatment no matter what their severity.
Well, thank you so much. It's so inspiring, because here in California, we're dropping our opioid prescribing, but the deaths are still creeping up, and experts do agree with you that we're not going to see those deaths go down until we can really provide treatment on demand wherever you live without a waiting list. So we've learned so much from Vermont, and we're going to be hoping to work on that here. I do want to say, for those who may not be familiar with it, we're building out, the state of California is building out addiction treatment and the safety net through what's called the Drug Medi-Cal waiver, and a key component of that is being able to offer buprenorphine in methadone clinics, which has been very difficult to do up to this point. So we're hoping that we'll see more methadone clinics emerging as hubs to be able to support these more complex patients. So I'm now going to turn it over to Dr. Jeffrey DeVito with the Marin County Drug Medi-Cal program. Probably a little bit more like Vermont than LA in terms of the population, but facing some real challenges with addiction treatment. So Jeff, please walk us through where you are and what you've learned.
Okay, sounds great. I'm tempted to say, can everybody hear me? But then I realize that nobody would be able to tell me if they could or they couldn't. So I'm just going to keep talking.
We hear you fine. You're great.
Okay, great. A real pleasure to be here. Thank you for inviting me. And I actually wrote that down when I was listening to Dr. Brooklyn's talk about the population of Vermont being 600,000. The population of Marin's about 250,000. So we are probably much more similar in size than to Los Angeles. As kind of a preface here, my presentation is going to be somewhat different than the last one about Vermont, in part because we're very much on the early part of development when it comes to the hub and spoke model here in Marin County, and I'm always in awe of what Vermont has been able to do and has been able to organize. And it always seems, when I hear about the Vermont system, it always seems so easy, but I know that each of those steps involved a tremendous amount of work and collaboration. So I'm really kind of in awe of what Vermont's been able to do, and we're trying to develop something of similar efficacy here in Marin County. So again, kind of moving over to California from Vermont. Get on here. Okay, so some background information about Marin County. I had mentioned before that we were, size-wise smaller than Vermont, but still kind of on par in terms of order of magnitude. I put some information up here. I'm not going to go into great depth about it, but some things that you start to, or that I started to recognize and appreciate in starting to look at how to implement and how to increase access to medication-assisted treatment on a county-based level were some of these things that go back to kind of, well, how is the county governed? What's the municipal structure? And in California, there are two kinds of counties. There's a general law county and there's a charter county. Most of the counties are general law counties. General law counties basically pin their laws and regulations to what state law and regulations are, and charter counties are able to kind of develop some of their laws more locally and adjust them more locally. In Marin County, as in pretty much every other county in California, we have a board of supervisors. It's an important thing, an important nuance of California to give credence to, which is that in a lot of situations, everything kind of goes through the Board of Supervisors. They are, on one hand, both the executive and the legislative bodies within county-based services and county-based administration. We have about 44,000 Medi-Cal enrollees. It's estimated that we have around 1,300 homeless folks. As many of you know, it's notoriously difficult to actually get an accurate number of what the homeless population may be in a particular area, and we do have the distinction of being being labeled the healthiest county in California. That being said, even the healthiest county in California has has a number of issues, and we can always do things better. So the way that I kind of broke this down and that I'm going to speak about a little bit here is kind of the two-headed monster of supply and demand when it comes to substance use disorders on a population basis. And, on one hand, you can, it's useful to kind of break things down by thinking about, like, what kind of interventions can we make on a supply side, and then what kind of interventions can we make to decrease demand on the other side. I have the logo here in the lower right-hand corner, which is RX Safe Marin, and very important to kind of note that this is a coalition within Marin County. I can't take credit for developing it or administering it, but I kind of am riding its coattails because it's been incredibly effective. It was brought into play before I joined the county and started working with the county. And in terms of what RX Safe Marin is it is a coalition that is primarily organized out of the Department of Public Health in our county, and the head of it is our public health officer, Dr. Matt Willis. And there are it's a coalition, so there are a number of different stakeholders that are participating in the coalition from, you can see these on the slide, the district attorney's office, the public defender's office, education, other healthcare providers, and most importantly, community members. The targets, or the things that we in the RxSafe Marin initiative and the coalition, the things that we've been trying to target are, basically the same things that many other counties and areas of the country are trying to address, which is, can we, on one hand, decrease the supply? In other words, on one hand, can we work within the community as a coalition to decrease the prescribing of medications, of opioid medications, and on the other hand, decrease demand for those by particularly kind of being able to refer people to treatment. So these are just some numbers of the high-dose opioid prescriptions from 2013 to 2015 in Marin County. I'm not going to linger too long on these, so I can move on to the hub and spoke aspects of this. But suffice it to say that the coalition's been actually very successful in decreasing the prescriptions for high-dose opioids, and we've also seen, kind of correlated with that, a decrease in the unintentional drug overdose deaths. But we certainly don't want to rest on our laurels, because we recognize that decreasing supply is one thing, but decreasing demand is really what will provide long-term stability to these trends. So in terms of thinking about demand, we can think about it in terms of two different areas as I break it down. One is thinking about it in terms of community-oriented primary prevention. This would be these would be intervention and prevention techniques that are primarily oriented around informing patients and providers about the risks and the dangers of opioids, invoking law enforcement's participation, as well as schools, local media, and those issues, those endeavors have been ongoing through the RxSafe Marin program. And then secondly would be to get people into treatment, that you can decrease demand by getting people into treatment. And right now we're really on the cusp of being ready to kind of go full bore into thinking about how do we increase access to medication-assisted treatment. And that's where I kind of came into the picture several months ago in trying to strategize about how to do this. Because there remains, the estimates statistically in Marin County would support the idea that 1 in 4 adults in Marin could use help for drug and or alcohol misuse. That's a big number. That's a lot of people, and many of those folks would potentially be candidates for some version of medication-assisted treatment, but in particular we're focusing on buprenorphine and folks who might need medication-assisted treatment for an opioid use disorder. So this slide is kind of a broad overview of, and I'm hoping that maybe some of the people who are listening to this would resonate with the, kind of what my efforts have been in terms of mapping the county and finding out, well, exactly what do we have in the way of treatment to begin with, and what are the barriers to treatment that exist in the county, and how could we utilize a model like Hub and Spoke to facilitate getting people into treatment, that utilizing what's already in existence in the county rather than kind of creating a whole new endeavor. I'm really proud of this slide because the color coding on this, I'm smiling here because I thought it was pretty clever, but the blue, the treatment options that are in blue, those refer to commercial insurance or other, so self-pay versus commercial insurance. The ones that are in red are facilities that are primarily, if not exclusively, for the Medi-Cal or Medicaid population. And then if you combine blue and red, you get purple, and that's the places that have some overlap in the sense that they serve a population that is mixed. They do both Medicaid and Medi-Cal and commercial insurances. So a couple to highlight here on this slide before I move on. One is what is here, the first of the purple ones, which is Marin Treatment Center. Marin is fortunate to have one methadone program, but narcotic treatment program. It's located in the center of the county in the city of San Rafael here. And I know many counties in California do not have an NTP, but we're fortunate to have one, and they have been also very forward-thinking in terms of developing their ability to prescribe and dispense buprenorphine in addition to methadone and provide intensive outpatient services and other behavioral supports for folks. The other to highlight here is one of the 4 FQHCs that we have in the county is Marin City Health and Wellness Center, which recently received a grant, had applied for and received a grant from HRSA to be able to access funding to be able to expand buprenorphine in their own FQHC setting. And so we have sort of you can sort of see things kind of crystallizing around these 2 areas, the Marin Treatment Center and the Marin City Health and Wellness Center. So again, I come back, I was kind of facetious about the pride that I was having in terms of the red and the blue turning, purple in the middle, because it actually, and that kind of maybe makes light of some of the real problem that we have, which is thinking about, servicing folks who have Medi-Cal as well as people who have commercial insurance, and thinking about, is there a way that when we develop a hub and spoke model that we can develop it and create an architecture in such a way that we could build it and grow it that would not exclude folks who are Medi-Cal or vice versa, people who are commercially insured. So how do we find that area that we could be able to grow and then develop access for folks who have either of these insurance options? So what did I do next? I started going around to various providers, different FQHCs, different mental health providers, different treatment venues in the county, trying to get a sense of what they were doing in the way of medication-assisted treatment, or what they may be interested in doing in medication-assisted treatment. And some of these may be very familiar to people who have already kind of poked around and gotten a sense of this, but some people would say, what are you talking about? Some people would say, we're not able to handle criminals. I don't want the liability. Can't do the drug testing. The number one thing, though, that I was coming up against in a number of different venues was, we don't want to be known as the place where addicts can come for this. We'll be overrun. And a corollary to that is, we don't want to feel like we're out on the limb and stuck and we have no support. So this would harken back to what Dr. Brooklyn was talking about before in terms of trying to incentivize providers to do medication-assisted treatment. One of the things that you need to be able to provide to them is some backup, some release valve to help support them with some of the more complicated patients. So we then, as with all things in life, you have to kind of focus, and you have to kind of narrow what your focus is going to be at the beginning, but keep an eye towards sort of future growth and the decisions that you're making on a small scale and how they may impact future big decisions that you might want to incorporate. And what we've decided to do here is really kind of start by focusing primarily on the Medi-Cal population. And in doing so, kind of focusing on the FQHCs, focusing on the county mental health providers, as well as the county subcontractors. It was mentioned earlier that California has the drug Medi-Cal ODS waiver. It's an incredibly complex thing. We could probably talk for hours about all the nuances of it, but we have gotten our waiver through at this point as a county. And one of the brilliant things that folks did, again, I can't take credit for this, before I came on board, was to ensure that all the subcontractors for the county are DMC certified. And by virtue of being DMC certified, and then by proxy then associated with the DMC ODS waiver, there are medication-assisted treatment linkages that are mandated. So this kind of development of medication-assisted treatment on the spokes, and then thinking about how to develop a hub, is very much in line with what the waiver would dictate. The other thing that, just as an immediate goal, other immediate goals that we've decided to undertake, one is to just flat out increase referrals to the Marin City Health and Wellness. That's the HRSA grantee that I mentioned earlier, that is now building capacity to do buprenorphine. And then building other internal capacity and building the hub and spoke connections. So the last one on the list is building the hub and spoke connections, because that's actually probably the heaviest lift of all of these. Building internal capacity, I'm taking over doing a lot of buprenorphine training. So we got a slide here and two slides here at the end about you know, providing buprenorphine waiver training myself, and then providing personal internal consultation, and then working to build internal champions in the various stakeholders who are part of, you know, what would be considered a spoke, and then work on building those hub-spoke connections, hopefully between internal champions at the various stakeholders, as well as the ones that are already in existence, like the FQHC that's already doing buprenorphine. In terms of the Marin City Health and Wellness buprenorphine clinic, we've set a SMART goal of getting at least 10 patients by May 1st referred from various other FQHCs into the Marin City. This is the HRSA Grantees Medication-Assisted Treatment Program. This is a rather confusing looking slide that I'm not particularly proud of, but it does convey in graphic form kind of what our ultimate goal would be, which is that on the top of the red line, we've got primarily Medi-Cal providers. On the bottom of the red line, we have primarily commercial or private providers. And the red line, when it's cutting across a particular venue, is designating a venue that is able to handle both. And ultimately, we want our hub, which, you know, our narcotic treatment program is the one exemplar of this, in the sense that they can handle both Medi-Cal and commercial insurance. So we'd like to be able to kind of build their capacity and increase their referral base. When I came on board in the county, I asked the narcotic treatment program what is the one thing that they needed most from the county, and they said they needed referrals. I said, oh boy, well, I can get you referrals. We just got to figure out how to do it in a way that makes sense. And utilizing that, so this is how we're thinking about the hub and spoke model, is that we've got spokes that are interested in doing it. We've got a hub that is interested in doing it. It's now a matter of kind of coordinating the pieces. So again, we're very early in this process. This is my last slide. We're very early in this process, so kind of juxtaposing this next to Dr. Brooklyn's presentation is, you know, a little daunting, but it does perhaps give a little bit better sense of what kind of challenges specific to California may come up, and also kind of shed some detail to kind of the tremendous amount of work that the folks in Vermont did that looks very glossy and nice now because they've done such a great job of being able to coordinate it, but it's actually pretty messy getting all the pieces to come together. So I'm not sure if I ran over my time. I typically do, but that's it for me.
You did great, Jeff. Thank you so much. And I really think that it was helpful to illustrate, first, all change is local. All journeys, 1,000-mile journeys, start with one step. And what's so interesting about Marin is I heard the story that a coalition meeting was focused on addiction treatment, and someone at the table said, well, we've got addiction treatment capacity and we don't get any referrals. And someone right next to them said, we're a community clinic and we have no idea where to refer people. There's not enough places to do treatment, and they're within a very small county and just hadn't talked to each other. So one of the key messages is sometimes just talking to the people in your own neighborhood and your own community, you can solve some of these problems that seem unsolvable. And just as a reminder, people don't know what these acronyms are. DMC is Drug Medi-Cal, ODS is the Organized Delivery System, and that's the new process to have counties be able to receive funding to build new addiction treatment resources for Medi-Cal patients. So now I'm going to switch gears and turn over to LA, and I thought I would share a couple fun stats about LA. It's 500 square miles, 40 million people from 180 countries, 140 languages, and no majority population. In fact, only about 27% white. So the things that LA faces are very different from Marin, which is why we're so happy to have the two together in one webinar to reflect the complexity of our state. So Dr. Claire McPhail is going to be presenting from UCLA. Take it away.
Hello, everyone. Thank you very much for allowing me to present some of the information on what's been going on in Los Angeles County. I really appreciate it. I'm going to focus on basically an overview of the Los Angeles County approach to the hub and spoke model, and talk a little bit about how we coordinated services to increase access to medication-assisted treatments. So in Los Angeles County, as was already noted, oh, why is my slide not forwarding? Oh, never mind. There we go. All right. So as was already known in Los Angeles County, we are a very large county. We're actually larger than 42 of the 50 states in the United States. And perhaps due to that, we've had some medications such as methadone widely available for decades at this point. But unlike the experience maybe described by Dr. Brooklyn in Vermont, even though we've had access to methadone for years, and maybe due to our longstanding social model history of substance use disorder treatment, that we haven't really, or I should say the culture of substance use disorder treatment in Los Angeles County has not really adopted the idea of using medications for substance use disorders. So the point of the hub and spoke model was to increase access to medications used for opioid use disorders, and a lot of the funding for this project originated out of block grant dollars. Later research, including evaluation done by myself and my team here at UCLA, allowed the county to apply for additional funding through SAMHSA in order to help expand the hub and spoke model. So the way patients typically are referred through the process is a lot of times they may show up either at a particular substance use disorder treatment program, referred to here as a spoke. They may also be referred to substance use disorder treatment via the criminal justice system, through mental health services, through primary care, etc. And at the time of the intake where they were originally sent for treatment or where they originally arrived for treatment, if patients responded that they had either an alcohol or an opioid use disorder, they were informed that there were medications available that might help with their treatment. At that point, if the patients were interested, they were given more information, and at that point they were typically referred to and sometimes transported to one of the treatment hubs. Now, the hubs themselves were 3 specific agencies, at least in this particular model, that one agency provided methadone as well as buprenorphine and naltrexone, and the other 2 programs provided mainly naltrexone. But if providers or rather clients were interested in taking methadone, we had several methadone or opioid treatment programs that they had easy access to. Now, before I get into a little bit more about the actual hubs in the program, let me talk about more of the expansion process. So as I noted earlier, one of the reasons why we wanted to do this MAT expansion process was in order to promote a culture change in Los Angeles County. So we are working to engage counselors and, in addition to that, certifying organizations to have a better understanding around the uses of medications for substance use treatment, and in order to ensure that there's adequate focus by the certifying agencies in their curriculums around MAT. So like Dr. DeVito noted, we had to do a lot of work to change the culture and incentivize our providers, even the substance use disorder treatment providers, to work with patients who were using medication-assisted treatments. So we spent a lot of time engaging in training and information sessions, and we had several both online and in-person trainings for counselors, as well as our LPHAs, the licensed practitioners of the healing arts, in order to have them better prepared to work with clients and patients who are receiving medications as part of their treatment. So the second area around our MAT expansion had to do with expanding the number of MAT prescribers. So we've been working with primary care and mental health departments, and also working with our substance use disorder provider communities in order to expand access to buprenorphine trainings. We've also been utilizing a lot of our DMC, our drug Medi-Cal medical directors, in order to get them licensed and prepared to prescribe buprenorphine amongst other medications, so that we can better utilize them to the full extent of their expertise. We are also looking at expanding the number of MAT hubs that provide 2 or more of the medications. So currently in the hubs, again, excluding the opioid treatment programs, at least initially, we had 3 agencies that were available to provide medications. And one of the reasons why these 3 particular agencies were selected for our initial hub and spoke MAT expansion process had to do with the fact that they had the infrastructure available in order to keep the medication either refrigerated as required or locked away as required, as well as the medical staff in order to administer the medications. These three agencies also had a long-standing relationship with the County of Los Angeles. And so we were able to easily, let's say, adjust their contracts in order to address these issues. So some of the next steps involve figuring out how to develop new hubs. In addition to that, SAPC, the Substance Abuse Prevention and Control Office, and the SafeMed LA MAT Action Team, we've convened 2 MAT Learning Collaboratives. And one of these MAT Learning Collaboratives really focused on primary care, while the other focused on the substance use disorder treatment providers. We've reasoned that engaging primary care is critical because that seems to be where the bulk of the potential MAT prescribers will be. So we want to make sure that while we're engaging the primary care providers through our MAT Learning Collaborative, that we focus mainly on buprenorphine, but we also want to make sure that our substance use disorder treatment providers also have access to information on the various medications that are available. In addition, that in our MAT Learning Collaborative meetings, we've had not just the hubs SUD treatment programs that I just mentioned, we've also been able to include our opioid treatment programs as well as several non-opioid treatment programs in order to get our programs to better understand how medication-assisted treatments can assist with the treatment of their patient population. So just to talk really quickly about some of the barriers we've come across. So we started this pilot project maybe about 2 or 3, actually maybe even several longer ago than that. And what we found through one of the pilot projects is that we have a need for education and training several times a year, probably at least every 4 to 6 months, just to account for the amount of turnover that we find within our treatment programs. And even if we prepare for the trainings on our own, if we decide to incorporate the medication manufacturers, we found these trainings to be more problematic. As I noted earlier, a culture change was needed for some of our providers, not just to understand the use of MAT, but to better accept patients who are currently or interested in taking medications as part of their treatment plan. So we realized that the culture change really requires administrative support at the executive level and for it to work its way down. And we also understood the importance of training staff on how to administer the medications. In addition, we found that some of the better outcomes we observed involved patients whose medication-assisted treatment was coordinated with the end of withdrawal management, and this helps in particular to reduce relapse and the possibility of there being problems with overdose. There were obviously some storage and security requirements with the use of medications. For example, methadone and buprenorphine typically have to be stored in secure locations, and naltrexone typically has to be refrigerated. But even with those particular requirements, we found that once we were able to address those, it didn't significantly impact how often or how many patients we could see or that the providers could see at any given location. We did find that there were some delays with coordinating with external medical centers. For example, a lot of our patients will go out or leave the actual treatment program, the substance use disorder treatment program, in order to receive to get their labs taken, to get information on blood work and that sort of thing. And sometimes coordinating getting the results of those tests and other exams have been problematic. So to address that, the County of Los Angeles has started the development of a universal consent form, which we hope will reduce some of this lag time. Now, the last 2 slides that I have are really just information on resources that are available. There's University of California, San Francisco Clinician Consultation Center. There's buprenorphine training resources, as well as additional resources involving MAT guidelines and protocols. And that is my last slide, so we have time for questions.
Wonderful. That was so helpful, and it's I've just been so impressed about how LA has taken on this problem, because you've faced very unique challenges and you've created a really massive, well-coordinated effort. A few questions came in the chat boxes, and I'm going to go through those and welcome others to put in questions, and anything we can't get an answer to, you can always email us. One question was, how do you manage information exchange in Vermont? And the answer from John was that they have case managers manage the referral back and forth from the hub and spoke so that they can make sure it's done efficiently and quickly, and all patients sign a consent to allow them to exchange clinical information. There was a question about, is bup used for pain in Vermont? And the answer was that both hub and spokes are using buprenorphine primarily for opioid use disorder first, but recognition that there's a lot of overlap in the chronic pain patients. One question about access to buprenorphine, and that just so people know, in California, you can get buprenorphine at a pharmacy with a prescription without any prior authorization. So starting up a bup program, you do not need to store it. You can get it at a pharmacy. And certain insurance companies like Anthem and Cigna have now removed the authorization requirements to make access a lot easier. The next question, that also for Vermont, can you explain more about the savings? In the Vermont hub and spoke model, were the savings just in SUD services, or were there savings in the medical services, because treating addiction actually saves medical costs?
Yes, can you hear me?
Yes.
So a paper was published last year, and what we looked at is the cost of taking care of people with a diagnosis of opiate use disorder before the hub and spoke model was developed. So going from 2009 to 2012, and looking at someone who had at least 2 encounters somewhere in the system, whether it was the emergency room, or they went to residential, or their primary care office. And we calculated what the average cost of care was for that person, and I believe it was somewhere around $15,000 a year was the calculated cost for someone that had 2 encounters for a diagnosis of opiate use disorder. So then, more recently, in 2014, in testimony to the legislature, the blueprint documented that they'd already saved $6.7 million in terms of reduced emergency room visits, reduced residential admissions, and reduced overall hospitalizations because of the number of people who were now enrolled in some kind of opiate treatment program. And just to put a spin on it, we have in Vermont right now 1.05% of all Vermonters are on MAT. We have 10.56 people per 1,000 on MAT. And so what we're seeing is that the cost savings, when we're following it, is that the cost drops to somewhere around $8,000 or $9,000 per person per year once the hub and spoke system has been employed. And we're about to come out with another paper looking at the numbers from 2013 on that will actually demonstrate cost savings. And the paper was written by Casper and Folland, and I can't remember what journal it is, but it's available if anybody wants to look at it for the pre-hub costs. Okay.
And we can get that information and send it out along with the link to the recording, because this webinar will be recorded and available on our website next week. I had a question.
Just the other thing I wanted to point out is that we also have a significant penetration into primary care. Most people with a substance use diagnosis and opiate use disorder, I think somewhere like 86% of these folks have a primary care physician. So we've really gotten people into primary care who have this diagnosis, and I think that's one of the key factors, is that having access into primary care and then getting them treated for their other things is key. So, we have a robust system for that.
That's great. We had another good question come in, because it's very difficult to get primary care providers on board with willing to prescribe. I certainly remember my first 5 patients with buprenorphine were so hard, and then my next 5, I wondered why I made a big deal about it and wished I'd prescribed for years. But certainly getting people past that initial barrier is tricky. And so I was wondering if maybe first, Desiree, if you could answer what's been beneficial, either in terms of training or making the heart and minds case to get more primary care providers interested in taking on this population.
I think one of the things, or one of the misinformation that some of the primary care providers have, is that they're not already treating these patients in their waiting room, or they're not already seeing these patients as just regular, let's say, primary care patients. So I think some of it has to do with the fact of getting the primary care providers to understand that these are just, normal people like anyone else, and that it's not the purpose or the goal of, at least not for my county, obviously, and not, I'm sure not for anyone else who's been on this webinar, to turn any primary care office into a pure substance use disorder treatment agency. It's rather simply to get them the information and the training that they would need in order to better treat a lot of the patients that they're already seeing.
Great. And how about you, John? What was effective? Because you got such big numbers in Vermont. Why did they sign on?
Well, I think, Jeffrey made a good point, and I think Desiree alluded to this, is that this idea of physician champions. And I think what happened is once you had a cohort of docs who were treating it, they could then be a resource for other docs in the community. I will say that there was a significant amount of political pressure in Vermont. As you probably know, our governor made his 2014 State of the State address solely about opiate dependence. And so there was a massive effort by politicians, governmental officials, local hospitals to really get doctors to take a bigger role in dealing with this opiate problem. And there was a movie that was made by a local filmmaker called The Hungry Heart, and it showed in most of the cities and high schools around the state, and there was like a groundswell of effort that almost shamed physicians into saying, listen, this is going on right in your midst. This is an epidemic. Can you guys do something about it? So I think the walls of resistance eventually broke down because so many people who were non-physicians took an interest and really kind of made it so that docs in the community felt now they had an obligation to somehow address, the number of people that were dying and all the different people that were using that didn't fit their view of who an opiate user was.
I'm so glad you say that, because it's true. We physicians are slow to change, but if one of our peers talks to us, it tends to be incredibly impactful. And that's what I wanted to bring up next. One of the most important things that we found that gets physicians not only to get the waiver, but then to start prescribing and keep prescribing, is to get some support from other clinicians who are doing the same thing. And as you know, nurse practitioners and physician assistants can now prescribe as well. There's the UCSF Warm Line, which is free and open to the nation, open Monday through Friday every day, and they have addiction specialists at the ready and waiting to answer your questions. So if you Google UCSF Warm Line, and we'll also put it in the email that we send out with the link, they are available to help you with clinical cases or to figure out how to solve problems. There's also the Providers Clinical Support System, PCSS-MAT, and we'll include that link, and if you Google that you can actually sign up for a mentor. And the California Society of Addiction Medicine has been very enthusiastic of providing mentors so that people who are getting started in prescribing can learn more. And we're also finding across the state more and more interest in collaborations to have local resources come together and learn together about how to provide this addiction treatment. The California Society of Addiction Medicine also has monthly webinars that are available on their website. These have been incredibly well received, and they're part of a statewide clinic collaborative for 25 clinics to learn how to integrate addiction treatment. The old recordings are on the website and available for free, and there's new ones that are coming out every month, and they've just been seen as very helpful and practical. Like, how do you deal with managing privacy restrictions, and how do you do these types of behavioral health interventions and short visits? Again, a really helpful resource. And finally, I just want to do a plug for our website. The California Healthcare Foundation has a website with many publications on medical system treatment. There's a very helpful document called Buprenorphine, Everything You Wanted to Know, that covers some of the research and information about the use in addiction and pain, and how you can do home inductions, which save time in the office, how you can do buprenorphine patch inductions so people don't have to go into withdrawal to get started on buprenorphine. Again, we're aiming to provide resources to you. If you have any requests for future webinars or things that you think that we can help with, please do email us. We're always happy to take suggestions. Let me just see if there's any other questions or any comments from any of the speakers before we close.
This is Jeff DeVito again. I would just add one other resource that may be helpful to some folks, which is that the American Academy of Addiction Psychiatry, the AAAP, also has a mentoring program. And in particular, if people are looking for additional support when it comes to co-occurring psychiatric and substance use disorders, that can be a valuable tool as well.
It's very exciting that suddenly there are so many free resources. The SAMHSA, the Substance Abuse and Mental Health Services Administration, has many free buprenorphine trainings that are either entirely online or online combined with live webinar or in person. There are free resources for nurse practitioners and physician assistants to get in the 24 hours needed to become a buprenorphine prescriber. In this very divided country, treating addiction is one of the very few bipartisan things that unites us. All of us have had patients, friends, or families hit by this epidemic, and it's very reassuring to see finally an effort to treat this as a chronic disease and no longer as a criminal offense. So thank you all for joining us. It was such a great webinar. I want to thank in particular our three speakers for sharing their experience. Have a good afternoon.